Hello, everyone. Get to my first slide here. I feel like it was particularly artful coming after that last talk, which was so excellent and shared some qualitative experiences, because often we are buried with numbers at CDC. But I really appreciate the opportunity to be here today and get to share some findings with you all. So the Autism and Developmental Disabilities Monitoring Network, better known as the ADDM network, has been around since 2000, reporting on the prevalence and characteristics of children who are 8 years old with autism in different sites across the United States. In 2010, 4-year-olds were added to tracking. And in this slide here, you see a map that shows which sites were participating in the 2020 study. And as was mentioned, the most recent reports just came out last week. So we released 2 reports, one on 4-year-olds, one on 8-year-olds. So the ADDM methods involve bringing together clinical records and education records within these surveillance sites and further abstraction of those records. So pulling out important things like what kind of, how did a child perform on IQ tests? What was their earliest recorded diagnoses? We're able to go into the records and pull that information as well. A child qualifies as having ASD. This is our case definition for surveillance, at least. So if they ever had a written ASD diagnosis in their records, or a special education classification of autism, or if they had an ASD ICD code that was in their administrative or billing records. And this shows the estimates over the years of ADDM, so we report every 2 years, and the most recent number, as mentioned, was 1 in 36, which was about 2.8% of 8-year-olds in the surveillance areas. And this was an increase from 1 in 44, which was 2.3% of 8-year-olds seen in 2018. One thing that's really consistent across years is a lot of variability across the sites. So we do kind of average them together and get that overall number, but there's lots of differences. This graph shows across all of the sites what the prevalence numbers looked like. So it ranged from 2.3% in Maryland up to about 4.5% in California. It also, and the horizontal line is that overall average number. The bars are broken down based on what evidence of ASD was contained in the child's records. The green is having that written diagnosis. Blue is children who didn't have a clinical diagnosis, but they had a special education eligibility of autism. And then the purple part of the bar is just having an ASD ICD code. And what's interesting about this is that we can see, even here, there's some variability in community practices, and for example, the extent to which there's some reliance on school identification as opposed to clinical identification, or clinical identification required for school services. One of the biggest findings this year, and I guess I'll start back in the history of it, this is showing the patterns in prevalence by race and ethnicity over the years that ADDM has been doing surveillance. And historically, there was lower prevalence among Black children, and then Hispanic children and Asian Pacific Islander children as those groups began to be reported. In more recent years, that gap started to kind of narrow, and in 2016, Hispanic children were the only group that had lower prevalence than white children, and in 2018, prevalence was actually similar across all groups. What was interesting, in 2020, a new pattern was seen where actually Black, Hispanic, and Asian Pacific Islander children had higher prevalence of autism compared to white children. And as mentioned, we think that this could reflect more equitability in how children are being identified. It's kind of early to know at this point, but And then, so the previous slides were dealing with our 8-year-old group, but this is really going to be where you see the primary finding of the early identification paper. And what we did, right now obviously it's just a blank graph, to kind of orient folks, we compared the incidence of ASD identification, and we have this for numbers of evaluations as well. We compared the 4-year-old group to the 8-year-old group, but during the same age window. And so we were essentially comparing kind of like the first 4 years of life for those two cohorts to say what happened over time. And we graphed this clearly as calendar months. And what you could see is that prior to March of 2020 for the children who were 4, there were large increases. So there was more identification happening in almost all of the months leading up to March of 2020 for that younger group. But then once March of 2020 hit, which as we all know was of course the COVID-19 pandemic, that progress was essentially wiped out. And what we saw was the disruptions led to those children who were 4 experience even fewer ASD identifications and having fewer evaluations compared to children who were 8, like what they experienced 4 years previously. So we thought this was really stark. I mean, I don't think it surprises anyone necessarily, but just to see how much of a drop-off this was, and we did show this by each site as well. And we thought this was really important for communities to kind of see what the impact of COVID-19 was on early autism detection. The data releases are a monumental effort. The reports are but a small part of it, really. So we have the 2 MMWRs that were released, but we also have the community report on autism, which many people prefer, and it doesn't offend us. It has most of the key findings summarized, spotlights on some of these, for example, the racial differences and early identification piece. It has those summarized, as well as each state having its own page of what they want to highlight for their community. We also have easy read summaries, which are even higher level summaries that allow, with the goal of having increased accessibility for people. There are also slides if folks ever want to take any of these findings and plop them into your own presentations. We have those available. There's also a data visualization tool which enables folks to compare data from 4 different federal data sources looking at autism prevalence. And you can see kind of what those data look like in your community. And of course, lots of website updates, making sure that everything is up to date. At this point, so believe it or not, all of that work was not all we've been doing so far this year. A lot of other studies have suddenly made it through, and if you were at ASF's last day of learning, my boss, Matt Maynor, presented this slide where he was kind of teasing some of the things that would come out, and this year I actually get to tell you about some of the findings of these. One of the most exciting things, we think, is that the first adolescent follow-up study results were published. So this was the first time Adam had some data on 16-year-olds, and this was a follow-up of 16-year-olds who initially came to attention when they were 8 in the ADDM network. And what I've chosen to highlight here, the study has tons of interesting findings, but this is showing co-occurring conditions. So this is if children ever had one of these conditions documented in their records at age 8 and then by age 16. And what you can see is children continue to be diagnosed with these co-occurring conditions, and there does wind up being this very high rate of co-occurring conditions. So this could indicate that, could indicate some special need for services and supports as children age and as they go through the transition period. And I should say that that prior work was led by one of our team members, Michelle Hughes. She also led this study that provided the first population prevalence estimates of profound autism. So this recently defined by the Lancet Commission. And what she found was that approximately 27% of 8-year-old children with ASD had an IQ less than 50 or were non or minimally verbal. And what this visualization shows is the prevalence of profound and non-profound autism over the years. Data weren't available for 2012 and 2014 because verbal status was not available, but you can see kind of an increase in prevalence in the profound group and a much steeper increase in identification of non-profound autism. And this study is pending publication literally any minute. It could happen, but I definitely wanted to share it with this audience. And then this report was also the first statewide and county level ASD estimates, where we had 7 sites who participated in a pilot study, and what they did was they linked statewide health and education data. And this enabled them to generate prevalence estimates for folks who are age 3 to 21. And it ranged across counties from 0.5% to 2.9%. But also really importantly, we compared for children who were age 8, we kind of compared that estimate to the ADDM, the full ADDM estimate. And what we found was that those were very similar. And so what is exciting about this, there's a trade-off in which this is less detailed information, so we don't have information about co-occurring intellectual disability, and we don't have information about early stage of diagnosis, but this can be a really efficient way of generating prevalence estimates for counties or other areas that have never had estimates before. So we thought it was a very, very exciting study. And then lastly, of course, I also have an excellent team to acknowledge. This is our surveillance team at CDC, along with Matt Manor on the end there. What ultimately is behind the numbers is people, and I just definitely wanted to give a shout out to everybody whose work made this possible, and especially our ADDM investigators, so the folks at sites and their staff. They work so hard and do such a great job, and the community partners who do a lot to then translate these data into action for their communities. And with that, I think that is everything. Oh.
I think it's wonderful what you've done, and continue to. Again, 2 questions. I'm an idiot. I don't understand how you do what you're saying about the incidence of autism by race, because it's being perceived that there's more children of minorities who are autistic, and then the second part is, does any of this look at the age of that diagnosis? So are you seeing this, for example, where black children being diagnosed at 7 and then they're showing up in the 4th grade, no different than the kid who was diagnosed at 2 years old?
Yeah, and could you clarify your first question a little bit, perhaps, when you say you have a question about it? Or?
Well, what's the conclusion you're reaching on the issue of the minority uptick?
Prevalence going
Is
higher.
that, when you say it's greater diagnosis of those individuals, which I probably agree, are we finding that those are kids getting diagnosed by the school when they miss out of early intervention, those whole type of issues?
Oh, that's a great question. And I think, so these prevalence reports don't dive as much into how those children are being identified, but we could certainly look more into, whether those are primarily school or clinical identifications happening. But what we do know is that the prevalence in those groups is now higher, and part of why we think this could be linked to perhaps more equitable access to services and things like that is we also see, and this was in the reports, Matt's 8-year-old report looked at prevalence by socioeconomic status, and we have also seen over time that whereas it used to be linked to having higher SES, we no longer see that clear association with socioeconomic status.
And the profound autism, are you looking at records of charter schools or the kids who are staying at home being taught by their parents? Or are you just looking at the public classroom?
Well, and so it's also a very, very good question. So when it comes to the education records, those are largely coming through public schools, but IDEA does require public schools to do child find activities in the community to be able to serve children who might be homeschooled or things like that. So, but then to your question about age of diagnosis, which I can't not answer. We have actually done a lot of work with median age of diagnosis, and specifically I actually published a paper doing a lot of work looking at the methodology itself and how median age it can be a very difficult to interpret measure, because what we are seeing with autism is we're seeing a lot more kids getting diagnosed early and a lot more kids getting diagnosed late, and so the median age hasn't really budged over dozens of years of ADDM surveillance, and we actually haven't seen differences between racial groups in several years, I'd say. So we've really switched a lot to looking more at cumulative incidence and looking at that because it can reflect, the prevalence and show whether, you can really compare kind of like that early identification if more kids really are getting identified or not. Yeah.
Next question here. Thank you for your excellent presentation and for the work that ADDM does. It's so important. I'm wondering if you could reflect a little bit on the difference between incidence and prevalence data and why we use prevalence data for autism. And also, second part of that question is, do you think expanded use of screening tools like the MChat has influenced the prevalence data that we're seeing and the rise over time?
Oh, those are both really good questions, and I'll probably forget to answer the first one as I do the second one, but the question about screening tools is a really interesting one, and ADDM currently collects test information, and so we get some MChat results. I will say that we have not found the best way of tracking screening tools, because often we are going to, specialist. Those are the clinical records we're usually getting are more kind of like specialist. Pediatricians' offices are many more in number than kind of the specialized locations where kids are going to get evaluated, and so we wind up looking a little bit more at that comprehensive evaluation side of things, and finding out if those kids got screening can be really challenging if it's not documented right there. And so it's likely that other data sets would be more amenable to looking at that, perhaps bringing in some Medicaid data, which ADDM is trying to do, and different things like that. But that's a really interesting question. And then your first question, which I promised to forget, was, oh, incidence and prevalence. That's interesting, and I think what I have to point to is kind of the history of the program, which it started in, I think, the late 80s, many years ago in metropolitan Atlanta. A lot of the studies were being done, and they started looking at prevalence of autism. And I'm sure there's a better answer to that question than I have, but it's interesting that I haven't really thought about it, but we did do these analyses based on incidents, this year to see how it kind of went. Oh, yes.
Thank you for your presentation. In one of your earlier slides, you showed diagnoses by state, and I was wondering why some of them had so many more diagnoses. I think California was really high up there, and then I think Wisconsin was really low, or not really low, but a lot lower. So is that because of socioeconomic status or just because of testing, or what was that reason?
And that's, of course, always kind of been the million-dollar question of ADDM, and part of why we think these data are really valuable is that folks can look across all these different states, and while we don't have space in the reports to deep dive into policies across all 11 states, that we hope that states kind of go back and are able to look at this somewhat. But we do know that California has a lot going for it. So the California site is located in San Diego, and the person who runs the site there has actually had a, I think, decades-long program emphasizing early identification and training pediatricians and doing a lot of work in the community for early identification. There are also the regional networks that, the regional centers that California has as well. And so it could really be a mix of what resources are available. It could depend on the particular requirements of that community of what children have to do to get diagnosed and all that. But so it's likely multiple things.
Question here?
Yes.
Hi. The 2023 appropriations bill funds an expanded network. What do you hope to see from the growth of the network?
Yes, thank you. And Stuart, right? And I guess that's the one group that I forgot to kind of mention in my acknowledgments is just partners like ASF and Autism Speaks and all these wonderful national partners that we have who did a lot of work that we can't do. And part of that is yes, we have been provided with some additional funds, and you'd be surprised how slow trickling down happens. But yeah, so expanding the network, I think kind of like with this last question of the differences across communities and just being able to provide more communities with answers of what's going on locally, because these data are not necessarily nationally representative. It's so important for places to be able to kind of see what it looks like in their site, just to then be able to plan for resources and things for their particular local community. So I think, yes, we're very excited to expand in multiple ways. So yes, I'm not sure how much I can say, but again, I think any day you should be seeing some more news about how we're able to expand with those resources.
Hi. I wondered if you could comment that at least in some previous years, kids who had enough descriptors of autism in their school or health records, even though they didn't have a diagnosis listed, they weren't classified, they were counted.
Yes.
I don't know, is this the first year that they weren't? I'm not sure, but yet the prevalence goes up, so I'm wondering if you have any comments on that.
Yes, yeah, this is also a great chance to go into ADDM history. So when the network was first founded in 2000, it was a completely different landscape of autism diagnosis and awareness. And I want to say it was somewhere around, I think 50% of children had a diagnosis in their records. And over time, that gradually became more and more. So ADDM used to find a lot of kids who didn't have diagnoses, but who had all these little points where they were like, well, they have all the things, they have autism. And I think I know, in 2016, that number was more like, I think 85% of children had diagnoses in their records. And so this was a lot of work that Matt Maynard did, really. He did an analysis looking at the full in-depth ADDM methods that involved clinician review of records and all of that, and compared it to this updated case definition, which just involves, counting whether that child was identified in the community, and found extremely similar results for both 2016 and 2014, kind of comparing those two methods. And so part of that is kind of a testament to how the community has become aware and clinicians have been identifying autism. And I will say, so this is the second year that this updated case definition has been used. So 2018 and 2020 involved the same sites and used this updated case definition. But the comparison showed similar sex ratios, all the other metrics that Adam commonly reports really weren't affected by this. But it has improved our work by a lot to kind of streamline. These data are actually published a year faster than they've ever been published. In case anyone's wondering, didn't you guys just release numbers? Yes, we did. It's been a lot of reports lately, but so we have sped up to be a year faster in part because we were able to really start just relying on what the community is telling us is going on.
Last question here. Oh.
Hi. Yes, something that I've been curious about for some time because, I was diagnosed late in life as an adult back in 2000, as a matter of fact, and as we all know, the reason for the dramatic increase in the rates has been largely because of the change in diagnostic criteria, especially after DSM-4 in 1994, not to mention all the subsequent dramatic increase in public awareness about autism. But something that I've wondered about, and I'm old enough to believe I have observed this, is that I suspect that another factor may be simply changes in societal attitudes. First of all, a lot of autistic traits, and I'm talking about non-profound autism now primarily, a lot of autistic traits which in the past might have been more tolerated have become much less so among many social environments, and also the kinds of special abilities that many of us have that used to be in very high demand are much less so right now. So with those two factors, so you have two societal changes there which would create a situation that whereas a mildly autistic person in the past would have been tolerated and been able to make a living and live independently, now would have a much more difficult time on both of those accounts. Have you been considering any of these issues? Thanks.
Yeah, I think that's a really good observation. And the surveillance system itself, of course, is unable to really measure these things. We certainly, how do you measure awareness is a really interesting question. But philosophically, I think there could be so many things at play, yes, kind of like what you're saying with the different societal issues. There's also information is more accessible than it's ever been, so people may also be able to find that information for themselves and say, this explains what I've been feeling my whole life, right. So, and then go on from there to take what steps they need to be diagnosed or continue. But yes, I think that's a really good observation too. Oh, and then do we have one more question? Are we done? Okay, thanks.